All right, everybody, let's get into it. My name's Mike. I'm the EMS liaison down south. Tonight, we are excited to have Claire Gam with us. She is a pediatric medical, attending medical ED physician, I'm sorry, with Children's Hospital. And I'm going to let her just take it from here and give you guys a nice pediatric emergency presentation. Let me know if you have any questions. We'll have a QR at the end for credit.
Perfect. Thanks so much for having me, everybody. I have to give you a disclaimer and apologize. Caught one of the kids' summer respiratory viruses, so if I'm coughing, I apologize. Hopefully, everyone can relate on some level. But Andra wanted me to talk about summer pediatric respiratory emergencies. And so we're going to be going through a really broad stroke view of kids' airway breathing. But we're also going to hone in a little bit more on drowning because that is oftentimes what we see in the summer. No financial disclosures. My big thing is I love engagement. I know Zoom can be hard and it's nighttime. Everybody hopefully is either eating dinner or will grab something to eat and drink during this presentation. Feel free to step away if you need to. But as much as you can use the chat, feel free to come off mute, whatever you want to do to engage with some of the questions or interrupt me if you do have questions. That would be great. Otherwise, my voice, especially my sick voice, is going to sound really boring. And then I will rely on Mike Dawson to interrupt me if I don't see a question. So, like I mentioned, we are going to review the fundamentals of the pediatric assessment triangle. I'm sure we are all too familiar with this, but specifically as it relates to airway and respiratory emergencies. And then we will also go through and discuss a little bit more in depth what pediatric drownings entail, what that pathophysiology is, make sure that we are all on the same page when it comes to our approach, our management, and our transport. I always like to say somewhere along the way, this phrase began to haunt us all. Children are not just little adults. And I think in some way or another, that starts to sneak into our subconscious and change the way we treat kids. And we get really hesitant, maybe a little bit afraid to do things for kids because A, we don't want to be wrong. B, kids are really scary. They can't necessarily communicate well, depending on how old they are, sort of like our geriatric patients who are on blood thinners. Kids can feel uncomfortable and we're not always sure if we're doing the right thing. And they're also a very rare population to take care of. The big thing is kids are much more resilient than our geriatric patients on blood thinners. They are not getting brain bleeds every time they fall. They are not breaking their bones every time they fall. And even when they do have a brain bleed or break a bone, somehow miraculously they walk out of the hospital more often than not just fine. So I want you to erase that fear of kids from your mind. I want you to think, be aggressive. Be as aggressive as you would be with any other adult patient, obviously using your pediatric tools, your references, your protocols, but please do not hesitate to treat kids, especially when it comes to airway and breathing issues, because the more you do for them, the better the long-term outcome will be, and the less likely they are to have some of those long-term complications. So just be aggressive. Don't be afraid. It's easy for me to say I get that because I'm a pediatric ER physician, but I swear you'll be fine. Adult versus pediatric crash, the big thing, and part of the reason we're always a little bit unsure, is this kid sick? Is this kid not sick? Is because children don't necessarily have the same vital signs, right? Little kids are tachycardic into the 200s just because they're crying and febrile, or as an adult, that would be SVT every time. Um, so one of the things that's going to really help you, and this is where you use your tools all the time, is to check a full set of vital signs. That is going to be, along with your exam, the best management approach to every single child. I always like to say, especially for a respiratory case, you know that's what you've been dispatched to. Assume that an end tidal CO2, if you have the capability of obtaining that, is a vital sign. So if you have a pulse ox without an end tidal in a respiratory kid, it's harder for you to interpret. And more often than not, those kids are wiggling their feet, they're wiggling their hands or their feet are cold, and your pulse ox is unreliable anyway. So the end tidal is going to tell you a lot more information about how they're ventilating. Blood pressures, if possible, for every single kid. I have also sat in triage with nurses and tried for 20 minutes to get a good blood pressure. If it's continuously high, the kid is looking well. You document what you have. make a little asterisk, say the child was moving, difficult to obtain, but at least you tried. And we, as the medical directors of the world, love to see that you at least tried. Maybe you didn't get it. We understand. But don't just say, that's probably going to be too hard. I'm not even going to try. And then when you have the ability to check a temperature, especially for some of these respiratory kids who are breathing really fast, it can be informative, right? A febrile kid is blowing off air to try to cool themselves down. So their respiratory rate's going to be a lot higher than it normally would. And interpreting that tachypnea, especially in the middle of flu season, and a kid that looks like maybe are we septic, maybe are we not, having that temperature on board can really help you interpret their heart rate and their respiratory rate. And then obviously, if you use your Broslow, if you use your tape-based measure, write down the weight that you're using for reference if you're doing anything for the kids. Jason Kodas, I don't know if any of you have interacted with him, but he loves talking about the 60s. He did not live in the 60s. He was not a child of the 60s, but he loves the 60s. So we have peace and love, but we also have some bad things for kids. Wasn't all peace and love. If you remember the rule of the 60s, you'll remember in general for kids around up to 5 years old, what we think of as red flags. So if we have a heart rate of 60, right, we're bradycardic, maybe we're getting to the point where we might be coding. A respiratory rate of 60, even in babies, that's going to be tachypnic. So if your respiratory rate 60, I don't care how old you are, you're tachypnic. Systolic blood pressure of 60, including in the newly born, ooh, that's going to be borderline, but especially once you get to a couple months old, that's going to be hypotensive. And a blood glucose, because we're always checking glucoses, 60 is going to be borderline. Lower than that is going to be low. And then I see temperature preference method. So everybody has different types of thermometers. Most people have the forehead scans. That works if that's what you have. For kind of 2 and under, I think rectal is the most valuable, especially when we start talking about drowning. Your core temperature or your rectal temperature is going to be what you are using for your interventions in terms of warming. And specifically, we'll put in like a rectal probe in the ER. But if you just have a forehead and that's what you can get, perfect, totally fine, absolutely appropriate. If you have the ability to grab a rectal temperature, that's definitely going to be more accurate. One of the things that we love to supply anyone and everyone with, if you would like them, are these pediatric resuscitation cards. Most people have some version of a tool with their agency that has what their protocol medications include and therefore what their dosing includes. So if you already have that, your field guide is a better field guide than ours. However, if you're always looking to change and adjust your field guide, if you have big updates coming through, or if you just want a different reference to have on hand, we are always happy to supply our pediatric field guide kind of version to you all. And so at the end of the lecture, we'll be sure to email out this email address, but always feel free to contact Jason if you would like any of these printed. Make sure to tell us the mailing address and how many you need. So now kind of pivoting a little bit, and this is where I hope the chat starts to blow up. What is your general approach to kids with respiratory distress? How are you walking into these calls, into these scenes? There's no wrong answers, truly. Y'all are quiet tonight. Okay. Um, who, I mean, I already alluded to this in our objectives, but who uses the pediatric assessment triangle? I love that. Prepare for a non-stable patient. Yes, we should always be prepared that the kid is not going to be stable. And then we love to just put away all the equipment we don't need and put away all the thoughts of anxiety and worry that we don't need if they're well appearing, right? But mentally preparing for a sick kid is going to always be your best approach for patients that we rarely see and rarely take care of because you just don't know what you're going to come upon. There's fewer of you than there would be in the ER. And so the more you can do to prepare and have more of your tools out, your equipment out, all ready to go, primed, pick the mask that you think you might need, etc., the less you're going to have to do on scene when you're actually stressed and trying to navigate family members or guardians and trying to navigate that sick kid. I still get nervous when we get calls from you all or our EMS partners here in Denver about a sick kid en route. I do a lot of pacing, I do a lot of pen clicking. I try to suppress those nervous behaviors. Um, but that is one of the things that I'm always kind of feeling and getting ready for while coaching the team on what we expect, what we need to get out. Work of breathing is the biggest thing you're looking at, right? That's one of those things where it's not an auscultation, it's not breath sounds, it's actually the general appearance. So that is going to be your quickest and easiest way to decide, is this kid sick or not? And what do I need to continue to go down this pathway for? And so if you see a kid who's comfortable, maybe they're playing with a tablet, maybe they're just hanging out, breathing comfortably in mom's lap, and it looks like mom's the one who has work of breathing and is very stressed, then maybe you can pivot and start to assess this kid, take your time for history. But if you walk in and you see that tripoding, retracting, kind of grunting, labored breathing, a kid who is maybe even not crying because they're focusing so much on breathing, then that's when you start to pivot and talk about sick kid management. I agree. Is anyone else in the house sick is a really important clue. Is this something that seems more infectious? Or are we talking about acute onset? Maybe there's a choking event that happened. Maybe there's something else that's going on. Those are all great thoughts. So again, our pediatric assessment triangle, we look at appearance and work of breathing. Both are very visual, right? And then circulation, which can be visual, but some of these are also going to be more of your exam. So for our appearance in a respiratory distress call, we're looking at their tone. Are they in the tripod position or are they really limp and floppy in our babies who are working? That would be concerning that they're getting tired, right? If they're inconsolable, if they're lethargic and not really interacting, they seem pretty listless. All of those are more red flags. Whereas a kid who seems to be comfortably sitting, walking around, calm. Maybe they're crying because they're scared of you, but you notice they're calm with family members. That's going to be more reassuring. Um, I always have to mention seizures and respiratory distress, they can go together, right? So asking about postictal periods, if you do see a kid that's pretty floppy and laying there, can be helpful for you. Duration of distress is awesome. That's going to be a huge clue into what's going on for you. And then looking at accessory muscles. For kids in general, especially under 5-year-olds, you want that shirt off completely so that you have a good picture and you're not constantly having to lift the shirt to assess, are your interventions working? Has something changed? Have we gotten to the point where we're apneic and it's harder to tell unless you can see chest rise, right? So all of those are really, really good points. And then the work of breathing, we've already mentioned, right? Accessory muscle usage, retractions, nasal flaring. I literally sit there with parents and make all of these motions with my hands and my body, trying to explain for return precautions, for instance, in bronchiolitis, what you should be looking for. Abnormal sounds. So those can be things like wheezing. If you're listening to the breath sounds, stridor, if you're just listening to the kid when you walk in. You can hear the croup cough walking down the hall a mile away, so you can probably hear it as you're entering the homes, right? All of a sudden you hear that sealed, barky cough, and you're like, oh, I know exactly what this is. I know exactly what I'm treating. Always have to make sure it's not a foreign body, but for the most part, especially if you have fever, nasal congestion, sick symptoms, you're treating croup. And then you're deciding, is this a sick croup that I need to intervene with a nebulizer on, or is this a stable croup and I'm just transporting to the ER? Apneas and gasping. So true apnea is a pause over 20 seconds, but pauses in breathing with gasping are equally as concerning as a true apnea. A true apnea means you've passed that point. We're bagging no matter what. We're in trouble. Pauses are clues that we're going to head towards the apnea and need a more critical intervention. And so the more you can do to intervene when you're seeing pauses, the better the outcome and the more likely you are to not have to proceed to, for instance, an intubation once they get to the ER or something like that. And then pallor modeling, cyanosis, those are obvious. You see a blue-lipped kid, like, well, the oxygen is low and I don't even need the pulse ox, right? So you're putting them on oxygen before you even get that number. You see pallor and modeling, and you know that they're kind of entering that respiratory arrest shock phase because they're so distressed, or they've just been working so hard that they're tired. They're dehydrated, right? Kids have a lot of insensible losses through their breathing. I'm always explaining to parents, especially in dry climates like Colorado, we have a hard time estimating how much they're losing, but we know it is a considerable amount. And so that is going to affect their circulation a lot faster than those lower altitude, humid climates, kids who are not breathing as fast. Some of the big things to consider and always remember for airways in kids, and I feel like a broken record when I say these things. So if all of this is just like old news to you, let me know. But with kids, right, they have those really large tongues, very anterior airways, especially the babies are obligate nose breathers. Really, by 1 year to 2 years old, they're pretty good about breathing through their mouth if they need to. But under 6 months, they really only know how to breathe through their nose. If their nose is clogged with mucus, they're going to have a really hard time. They have a much smaller airway diameter, which is why we see croup pretty much only in those little kids. Very rarely are we seeing it in the like older school age and up. I always say a kid's croup is an adult's laryngitis, right? Because it's essentially tracheal swelling, but in a kid, that narrowing essentially takes that space into just a tiny little coffee stirrer straw size. The cricoid cartilage just below their cords is going to be the narrowest area. So always remembering that as well for some of our interventions. And then they have gigantic heads, right? You look at a baby and that's why their head is flopping everywhere. And you have to support their head because their head is so much bigger than their body and they don't have great control with their neck and their necks are very fat and short. So it's just made to be an obstruction, which just doesn't help our job. But at least we expect obstruction essentially just positionally. And we know automatically we should be repositioning airways as we're intervening for respiratory distress. And so, one of the things in your assessment of the airway itself, not even getting into the lungs and the breathing, is looking to see is the airway open at all? You know, is the kid scrunched over in mom's lap and you just kind of want to lift their head and then suddenly they look and sound better? That's great. Do they have a hoarse voice, stridor, any other vocalization? Does it look like their tongue is causing an obstruction? Are there a lot of secretions in their airway? If you see a lot of drooling, that can mean sometimes that there's a lot of swelling in the neck, in particular the trachea and the esophagus, so they're unable to swallow comfortably, and that would indicate potentially a compromised airway. We think about drooling a lot more with things like croup tracheitis and then any of those neck abscesses, like deep neck space infections, RPAs, or peritonsillar abscesses. Um, and then any kind of abnormal sounds, like I've already mentioned, the stridor is always going to be that inspiratory sound. And so you'll kind of see them lift their body as they're breathing and try to take that big breath in. You'll hear that squeak. More often than not, families are going to call dispatch and say my child's wheezing. They don't know what stridor is, right? And so it's up to you to arrive on scene and decide, is this really wheezing or is this a very loud stridor and it's a totally different problem with very different interventions. Suctioning, we're going to go through in a little bit. One of the best things you can do for the baby airway or the little toddler airway, in addition to obviously opening up their airway. So optimizing position, we always talk about the sniffing position in our littler kids who have those really big occiputs. So the back of their head is just massive, right? And then it puts them in out of balance positions with the rest of their body. So bringing that head up with a shoulder roll and just in that straightforward sniffing position, not hyperextended, not hypoextended, is going to be your best friend for these little babies. And this is an example of that, right? Instead of a neck roll, where they would still actually end up with their anterior airway crunched over and obstructed, you're putting them on a shoulder roll. It's a similar concept to some of our morbidly obese patients who need a lot of shoulder rolls to help open up their airway. So think of it somewhat like that, but making sure instead of hyperextending, you're in that sniffing position. Some of our airway adjuncts, right? So I don't know how many of you use NPAs or OPAs commonly. I will say that I love an NPA for a postictal patient who's got a little bit of stridor, seems to be kind of sonorous, right? Snoring a little bit. I don't care how old you are. I grab the NPA because one of my indications that you're protecting your airway a little bit better is when you're continuing to grab that NPA and try to take it out. And that tells me you are awake enough to be bothered by this thing in your nose. I'm a little bit less worried about you now, but I'm not worried about you either when the NPA is in because I know I've opened your airway up. So NPAs for me and the altered mental status, the TBI, the postictal, or the seizures are one of the greatest inventions of all time. I don't use OPAs quite as often, I'll be honest. In the emergency department, we just have, right, the ability to go straight to intubation, and kids will have a gag reflex for a long time. And you don't want to put this in if you have a gag reflex. This is great for kids with lots of vomit, kind of secretions, trying to keep that airway open. If you have a bag, right, and you're bagging them continuously. So I think the OPA with those really obtunded, unresponsive kids is still a fantastic option. I just tend to reach for the NPAs more often, simply because of that gag reflex angle. And then just a reminder, the OPAs you measure near to angle the posterior mandible, as you can see in this picture, and the NPA is the tip of that near to the tragus of the ear, as you see in this picture. You really only want that hole to be, or the diameter to be as wide as that nasal passage opening. If you're meeting a lot of resistance, even with lube on, you probably need to size down. And sometimes it's just trial and error. You think you got it, and then you meet a bunch of resistance because they're so swollen in their posterior narrow space. So you have to size down. Similar to, for instance, when we intubate a kid and we have a couple of different sizes of tubes, if their airway is expected to be swollen because you meet that narrowing just below the cords. Nasal suction. This is a gross picture, but this is the reality of the life we lead in the pediatric ER, especially during the winter months. However, we're seeing a lot of human metapneumovirus this summer. We're seeing a lot of those cold viruses, clearly, case in point. And so nasal suctioning, especially for those kind of 0 through 4-year-olds, is your best friend. They really are not coordinated. They don't know how to blow their noses yet, and it just builds up and builds up. And the illustration I always use with parents is imagine how many times you blow your nose during 1 hour when you're sick. I don't think you pay attention and I think you lose count. So your kid is just waiting and waiting and waiting for you to blow their nose for them, right? We don't want to overdo it with suctioning when we're talking to families, but you cannot overdo it with suctioning when you're transporting a sick kid. Don't worry about inflammation. Don't worry if there's a little bit of bleeding. You have to get those secretions out so you can clear the airways so they can breathe. So you really can't be too aggressive when it comes to suctioning. I will tell you that when we do this in the ER, it looks like you're waterboarding the kids because you get them bundled into a towel or you have them somehow restrained so that they can't grab you. You have one person kind of holding their head, or you put their arms above their head so that they will self-hold their head. If you have fewer people, that works a lot better because then you can just hold their two wrists together, which are pretty small. And then you're squirting 1 or 2 drops of saline, suctioning, a couple more drops of saline, suctioning. Give them a break before you go to the other side so they can kind of sit up, catch their breath, but then do the same thing all over again on the other side. And it is a couple-minute process when we are getting a lot out. And the family always feels a little bit uncomfortable, but you just explain your child can't breathe because their nose is full of secretions. We have to get these out to make them feel better. And usually at that point, the family's like, yes, I agree. I don't want to do this at home. Go for it. Oxygen delivery devices. So this is another really important conversation. You know your equipment the best, but becoming really familiar with the equipment that you have for kids is going to be a time saver. It's going to mentally offload that stress when you have a lot going on, and it's going to be a huge, huge help when you're on scene with a sick kid. I always can include suction as part of my oxygen delivery devices, right? Because if I have a kid whose nose and whose mouth is obstructed with vomit or secretions and mucus, the oxygen delivery devices that I have here are not effective at all. So you should always think of suction for kids as part of your oxygen delivery system because it's just going to make it that much more effective. So especially nasal cannula, it's not doing anything if you're just blowing air into a big water bubble. Simple masks are fantastic. Non-rebreathers, and low flow nasal cannulas, those are probably the three we're going to see and interact with and use the most. Unless we get to that point where we have a kid who is not ventilating appropriately, and then we're using obviously our bag valve mask. One of the things I always recommend is at the start of a shift or the start of a week full of shifts, just going through your pediatric bag, making sure that you have all the masks correctly stocked, right? You have all your sizes, that you're familiar with your BVMs, that all of the parts are there. I will tell you because we don't use them as often for kids in our EMS world. Sometimes there will be like that one critical piece, that one critical hookup that's missing, and that will derail your entire management plan. So just making sure I know that this is part of regular checks for your teams anyway. But for you personally to take ownership of that, to kind of mess around with it before you're on an actual call is always going to be helpful and instrumental for kids. And then the last thing I wanted to go through, and we'll go through this a little bit more, but for oxygen delivery systems, there's different levels of a fraction of inspired oxygen or FiO2 that you can achieve. And this will matter obviously when we talk about drownings or we talk about any profoundly hypoxic kids, because you need to know how much oxygen you can actually deliver to those patients. And you want to pick the method that's going to get you the highest FiO2. So for instance, a non-rebreather, you're almost at 100%, which is similar to like a high flow nasal cannula. So this is going to be the best oxygen reservoir and oxygen delivery when you have a hypoxic patient or a patient who you're worried is sustaining injuries from hypoxia. For the patient that maybe just needs a little bit of flow for work of breathing, just needs a little bit of oxygen when that like bronchiolitic who's 85%, low flow, simple mask, totally appropriate. But just be aware that you're maxing out for the low flow cannula, especially in those older kids who are crying and breathing through their mouth. At an FiO2 of 40%, simple mask is usually up to about 60%. That also depends on how cooperative they are. This is a reminder, room air is 21%. So you're already achieving more oxygen delivery than you would be if you just left them alone. And this is where using the pulse ox and the end tidal together to assess for respiratory distress is going to be super helpful. One of the things that we also are probably all familiar with is that kids don't like to sit still. There's this funky band-aid on their finger, on their toe. They literally will only focus on this red light or instrument that's on their, extremity, and that's the only thing they can see. And they don't like it, and they're moving it, and you're doing your best to kind of slam it on their finger and get one good wave form so that you can get a number, and it's the bane of your existence. So that's where using end tidal with the oxygen saturation is going to be helpful for you to kind of get a better sense of not just their oxygenation, but their ventilation. How sick are we really? The kids who are so lethargic that they tolerate the SpO2 and end tidal CO2 should already be on your radar as the sick red flag kids, when they're in that kind of early toddler and baby stage, because those are the kids that should be irritated if their mental status is normal by the fact that you're getting vital signs. I learned this in residency and have incorporated it into my practice in kind of the big stroke way of understanding why oxygen delivery matters, why our devices matter, when I'm approaching sick kids. And so for a kid with respiratory distress, and especially as we talk about drowning, you do not need to memorize this equation. But what I want you to remember is that oxygen delivery is dependent on a couple of things. And one of those really is that fraction of inspired oxygen. So the more you can give them that arterial oxygen saturation, the better the oxygen delivery to those organs like the brain, the heart, the kidneys, the gut, the muscles, and the better they are going to do in the long run, because you're limiting that progression into lactic acidosis, that anoxic injury, the hypoxic ischemic encephalopathy, and some of those other critical detrimental complications that can come with hypoxic injury. And so that's where remembering that oxygen delivery matters. It's going to slow the progression into shock and lactic acidosis. And it's dependent on a couple of things. And one of those is the fraction of inspired oxygen is really all you need to know. I already went through this a little bit, but just two other charts. They're easy to visualize and see where your best oxygen delivery is going to come from when you're actually trying to increase that fraction of inspired oxygen. So for you all, just remembering that the non-rebreather is really going to be your best bet. Um, some interfacility transports are going to have high flow or be able to take a patient who's on high flow. Critical care transports are going to have the BiPAPs, right? So for you all, non-rebreathers, best friend when you need a lot of oxygen. A brief stop just to say blow by oxygen is one of my soapboxes. And so I apologize if you've already heard this from me. I think I probably talked about it in my talk last year, but just reiterating again, this is not an evidence-based intervention. Please do not use it. We all have that transient blow by while we're trying to set up other interventions. That's different, right? We understand the kid pushed it off. You're just kind of holding it near their face as you can reorient them, get them a little bit safer restrained, and put the oxygen delivery device back on their face. But it really should never be a part of your definitive treatment plan. I don't want to hear call-ins, hi, we're transporting this patient on blow by, because that tells me that that's your whole plan, right? Um, Especially in kids who really do need oxygen or those with true ventilatory failure. Unfortunately, you're failing to treat them appropriately, and you're not giving them what they need. So don't think of blow by as a definitive treatment plan. Think of it as that transient kind of band-aid while you're getting to your goal plan. And I know that this is a very common scenario, especially in a moving ambulance and a terrified kid. And so I'm not trying to place blame. I'm not trying to say you're doing something wrong. I'm just trying to say, as a culture, because this was very much a part of our kind of background, even in pediatric emergency medicine. But as a culture, we're trying to move away from this and understand why it's so important. If the kid really doesn't need anything, then it's okay to just pause and let it go, right? But if you have a kid who truly is hypoxic, and so you're taking it off, putting it on, taking it off, putting it on, that's going to cause more problems in the long term than just securing it to their face. Bear hugging them, utilizing the parent, explaining this is really important for your kid in order for them to get better. We do all of those things kind of like we would do with suctioning. Um, at the end of the day, if there's really just no way the parent isn't cooperating, it's just you in the back of the ambulance, everyone understands that, right? But if you have the resources or if you have more people on scene that you can delegate to ride with you just to hold the kid still, that's going to be better in the long run for the kid. All right, we're going to quickly shift into breathing, but I really do want to focus most of our time on drowning. And I told Andra I was hoping to get you guys out before 7:30. So I'm going to run through breathing really quickly, but want to pause. Any questions about airway before I move on? Okay. Again, like I said, please feel free to put them in the chat as we're going. So breathing, right? We've talked all about upper airway. Now we're looking more at that respiratory rate. We're looking at those retractions, right? All of the things we've already talked about with accessory muscle use. And then we're recognizing that in general, kids are going to be breathing faster than adults, but that does not excuse us saying, oh, yeah, their respiratory rate's just high because they're a baby or because they're little and they're crying. We do need to correlate their respiratory rate with our exam as a whole. So, like I already mentioned, do we have increased work of breathing with retractions? Or my breath sounds abnormal, which can be, they sound really wet. It sounds like there's a lot of fluid in the lungs, that kind of ronchi sandpaper sound. I really don't hear air going in like I thought I would, or I'm hearing wheezing everywhere. And I don't know if that's because there's mucus or if because this is a kid with asthma, but they're not normal, right? And so all of those things together are going to be really important as we're looking at breathing. The rate, like I already mentioned, is helpful, but it's really more about that overall visual of the work of breathing. And so usually I'm not going just based on a number when I'm assessing respiratory distress. The end title, I've already mentioned this, and I'm going to keep mentioning this, is going to be a really helpful correlation and interpretation of what you're seeing. If the kid isn't breathing very fast, but just looks like really tired, you're not sure if you've hit that point where they're going down on the curve. Now they've been breathing fast for so long, they're getting too tired. The end tidal is what's going to help you interpret that. Is it that they're better or is it that they're worse? A higher end tidal means they're worse. A normal end tidal or a really low end tidal probably just means they've been tachypnic for a while. They're feeling a little bit better. I always do caution the like end tidal of 20 and the tachypnic kid can quickly turn to a high end tidal. So make sure you continue to monitor, continue to pay attention to that. Interventions for breathing. Medications we think about for croup, for instance, nebulized epinephrine. For asthma, we think about nebulized albuterol. Those are going to be kind of your big respiratory medications. Don't forget about intramuscular epinephrine for something like anaphylaxis or even for escalation of an asthmatic. But most of the time, that's really all you're giving for these respiratory kids, because more often than not, you're suctioning, you're giving oxygen or flow. If you really need to, you're bagging them. If you have a sick kid that you've been bagging for a while, don't forget that they're going to very quickly develop a competitive abdomen with the fact that their belly's going to blow up so much. So either pushing on that, I kind of push down and up towards the ribs to help secrete out some of that air and vomitus. Got to be careful about it because you don't want them to aspirate. But at the end of the day, breathing, bagging is a little bit more important than the risk of aspiration. We can treat that. So if you have an NG tube, great. More often than not, I'm honestly just manually decompressing those babies and those toddlers whose belly fills up really quickly. If you suddenly find that a patient's really hard to bag and they were initially easy, the first thing I look at is, have I blown up their belly? Decompress that. Suddenly they're easy to bag. That was your problem. Decompress that. They're still really hard to bag. You need someone to listen for breath sounds to decide if maybe you've blown a pneumothorax. Not your fault. It can happen. That's why we just like to bag until we see chest rise. We don't want to give breaths that are too excited and overwhelmed for the kid in their tiny little rib cage because they're very compliant. And these kids usually have restrictive airway disease or restrictive lung disease. So those are usually the two things. You also want to make sure, first and foremost, that you've troubleshooted that your bag is hooked up appropriately. So something blew off, you didn't realize that the valve wasn't open correctly. That and an equipment failure is more likely the problem. Kind of like when we talk about an abnormal EKG, check lead placement first. Issues with your bag, check that the bag is hooked up correctly, and then think about those other things. So decompressing the stomach, is there a pneumothorax? This is just an example of the things that we see in kids, right? So, talking about a respiratory distress, and you're hearing stridor, but you're also hearing diminished breath sounds. This was very acute. You asked about duration, as Josh so astutely mentioned in the chat. And they get to the ER. You've done everything you can just to kind of keep them comfortable, make sure they're open. You tried an epi, it didn't change anything. And then you get the x-ray, and of course, there's a big coin right there. So there are some things that you just can't change, but you do your best. And it isn't wrong to overtreat a kid. So giving foreign body aspiration and nebulized epinephrine because they have stridor, that's actually probably helpful because they do have some surrounding inflammation and swelling from just having that coin there. And so you're making them more comfortable potentially as you're getting them to the definitive care they need. So again, this was just to illustrate sometimes things surprise us with kids and we do the best we can, but there are times where it's just out of our control. Early versus late respiratory distress signs. So these are the ones where you're asking, how long has this been going on? If it was really sudden, how sick is this kid, right? So early signs are oftentimes going to correlate with respiratory rates that are slowly going upwards. The late signs are the things where we really start to see those downstream effects. So hypoxemia, kids who are tired because they've been working and the hypoxemia has now taken an effect in sort of that end organ perfusion state. Those are the kids that we really have to be the most aggressive in our interventions. The early signs tell us we need to intervene, but we can kind of take it step by step, depending on how long our transport is. We might start with just some basic oxygen delivery. We might start with just some suctioning and start transporting and see how we do. But for our late signs, especially that cyanosis with hypoxemia, really tired kid who looks like they're starting to pause, That's where it's really important that you start more aggressive than you even might think you need to, because you want to turn them around before the respiratory arrest happens. And as we all know, respiratory arrest is going to lead into a cardiac arrest. So we're always trying to prevent that. For the late signs list, just so you know, these are the kids who, when they walk into the ER, I'm either starting them on BiPAP or I'm looking at, do I need to be bagging this kid? And so that's what I mean by aggressive. Using your tools, usually these are the kids where an NPA and bagging is probably going to be your best bet. More often than not, we don't necessarily have PEEP, CPAP, BiPAP, right? And so you have to be that positive pressure for them. And then obviously medications can be really helpful. So sometimes, depending on what I think might be going on, giving a dose of like a push dose or low dose epi can be really helpful as well. Always use your protocols, but I know protocols are variable and a lot of people do have written in, especially for someone like an asthmatic, that they can use low dose epi. So this is an example of retractions. You can see
every patient is retracting.
those subcostal retractions here. You can see some of the rib spaces are defined. That's what intercostal retractions are.
Working really hard for each breath.
Overall, this kid is sleeping. He's not head bobbing, but he is breathing faster and he is breathing a little harder. So there he went to try to smile a little bit. So I wouldn't say that this is a really sick kid, but I would say that he is someone who we're watching their work of breathing. And then this is just an example of more profound belly breathing with those subcostal retractions. And you can hear the grunting. So what's happening with that sound the baby's making is that he's actually stenting his airway open so that he doesn't lose his PEEP at the end of every breath and then have to work even harder to inflate his lungs. So that grunting is actually a stenting to maintain PEEP and basically be a self CPAP. And that's where we get really worried, especially in our babies, but in our little kids who really don't have that much muscle tone, muscle energy, overall energy. That's where we get really worried and would want to do more for them. And I apologize, my niece is upstairs making a lot of noise if everyone can hear any background noise. We're gonna skip this one. Let's see if we can get this head bobbing. Perfect. So this is just an example of a baby who is head bobbing, since we talk about that a lot. And it's similar to grunting. It's just trying to, again, use those muscles to open and close the airway instead of just relying on the breath itself. And it is a more late sign, more significant sign. One of the best things you can always do with all of our patients, adults included, obviously, is master the basics of bagging. It is really hard to get that perfect EC clamp. The one thing I always like to point out is the standard EC clamp on little kids, when you have a big hand especially, is going to obstruct their airway because your clamp is going to push down on their very, very floppy, pliable trachea, and you're going to accidentally close their airway. So one of the other things when you're bagging a patient is to just look at your hand position and make sure that you're just under the submandibular space right here, and that your hand is not occluding the trachea itself. In adults, it's a lot harder to do that because you're kind of along that SCM ridge. But in babies, it's really easy. And because it's floppier, just a tiny bit of pressure can close it. So work on that. If you have SIMS, that's always a great skill to practice. Oops. Example. Two-handed technique. If this is going to be a long transport and you're bagging that kid the whole time, it is exhausting to do this one-handed. You are going to end up letting air start to leak through the opposite side of the seal from your EC clamp. So if you have the resources, you have the staff, two people on bagging is always better than one. Even in those babies, it's just so easy for your hand to shift positions, for things to happen. So not having to pay attention to your rate, your pressure, is the chest rising, and am I holding this perfectly? It's a lot for people to do. So if you can get two people on this, it's going to be so much easier. For the ones who maybe are more transient, one hand and bagging, totally okay. You're just setting up equipment, totally okay. But if you're anticipating a prolonged transport with bagging essentially the whole way, for instance, a postictal patient that you don't know when they're going to wake up, or they got versed and so they are a little bit more respiratory depressed, those are the ones where two people can make a big difference. All right, so we have this kind of thought exercise, is what I would say, that we'll run through really quickly. Just to say, what are all of our summer respiratory distress causes, right? So we have dispatch call for a 5-year-old with respiratory distress. There's a couple different scenarios. One could be, let's say, after playing outside. One has been going on for the last few days, worsening overnight. And then this third 5-year-old was found in a swimming pool in the neighbor's backyard. So what are your thoughts for the kid who's playing outside with sudden onset respiratory distress? What would be sort of top of your differential or within your differential that you're thinking about and preparing for? And then feel free if you want to answer for any of them. Any thoughts? The third one being very obvious. Ooh, allergic reaction. Love it. Yes. Absolutely. So asthma, allergic reaction after playing outside, 100% of the time, I'm thinking it's one version of that, right? Did this kid get into something environmental? Was this kid stung by a bee and they have a bee sting allergy? Or is this kid someone who just like exercise asthma, heat, environmental, got worked up, and now is having an asthma attack? And especially with that acute onset, those are really the two I would be thinking about. Rarely are we going to now see this toddler who ingested something while playing outside and they have a foreign body. Foreign bodies are always on our differential, but more often than not, allergies or asthma. And then let's say the last few days, worsening overnight last night, mom's calling you kind of early morning, 5 a.m. So those are going to be more of those infectious kids, right? So maybe croup, yep, RSV, perfect, viral infections, where it's been building. And as we all know, bronchiolitis a couple of days in, even croup a couple of days in, is when we're going to start to see that overnight worsening. And that's when we start to see everyone show up in the ER or call 911. They're not sleeping. They don't know what else to do with their kids. The secretions are all building because they're laying flat. They don't have gravity keeping them down. They get worse. And then found in a swimming pool in the neighbor's backyard. It's terrible, but should be pretty obvious. Yeah. So worrying about a drowning, and we have a respiratory distress from a drowning. And so those are our biggest scenarios when we think about common summer pediatric respiratory emergencies. We always have RSV start to show up in the summer. Interestingly, this summer we haven't seen as much. Any of the other viral URIs. In kind of southeastern Colorado, there are, and I know Kansas, Nebraska, a lot of our regional areas with agriculture as a primary source of income and primary industry. There's a lot of organophosphates and pesticides. So kids in those rural areas, you have to think about, is this an intoxication with something like an organophosphate? And so you're seeing profound, secretions, they're wheezing, they're bradycardic, thinking about our organophosphates can be really helpful. But in urban areas, a lot less likely to be something like that. Drowning is a big one. Traumatic injuries, right? So e-bike, golly, I don't know how many of you are seeing e-bike injuries just like skyrocket, but it's a big thing across the country. And in Denver in particular, we've just been seeing a million of them. They're actually starting a study to try to evaluate essentially frequency and rate of these accidents so that we can start to advocate for more strict laws to prevent these injuries. But we've seen a tension pneumothorax and an 11-year-old e-bike injury, hemothorax, and those car accidents. Atelectasis due to painful injuries, always thinking about that. You have mountain bikers or someone who fell and now has rib fractures. They're going to be stenting and then develop atelectasis. Less common, I don't know why it's not capitalizing my E, but a lot of people traveling across country, across oceans, really long haul flights. You might get that early teenager who, for whatever reason, is on medications that put them at risk, maybe is an unknown factor V Leiden, and suddenly they have leg pain and a PE. So we don't exclude those, they're just less common in kids. And then one of the other things we're seeing a lot of, and I'm curious if you all are too, are envenomations, specifically rattlesnake bites this summer that have been really, really severe and extreme. And kids coming in either profoundly tachypnic or profoundly bradypnic, where they're just turning into these shocky atnic kids who I think we've had 3 or 4 intubations at children specifically from just local areas, not even transports in from out of state. So all of those things, and then the typicals, right? Seizures, any kind of cardiac failure, they're going to all be in your bucket. But the most common things we'll see are increase in asthma and then unfortunately drownings. Your toolkit, we've already gone through this, just a brief summary to go over all of our airway breathing pathway stuff. So suctioning, mastering, the correct open airway position, your oxygen delivery devices, NPAs, OPAs, BVMs, making sure you know where your albuterol is, if you have ipratropium with that albuterol, nebulized epinephrine, IM epinephrine. Don't hesitate to use this for critical asthmatics who are not responding to your nebs. McGill forceps for the choking kid, and making sure to just troubleshoot, work with this equipment often, even if you haven't had a call in a while, so that you're familiar. All right, now we're going to transition into pediatric drowning. And really the focus on this is understanding the pathophysiology, your management, and the importance of transporting these kids, even if they seem stable on scene. We have reclassified with HA in 2024 drowning as a whole because there started to be all these offshoots that people were naming dry drowning, delayed drowning. And it's, all over blogs and posts and Instagram scaring people and assuming that their kid's going to drown even after, an event to just swimming in the pool. What we've decided to do is rename it fatal or non-fatal drowning. And take away some of that other very confusing terminology. So for the sake of time, I'm just going to briefly run through this. This is a case that I'm going to pull through for the whole discussion. But just to give you a visual, this is a case that I've had in the past when I worked in Texas, lots of swimming pools and backyards in hot Texas, but very likely could happen anywhere. So a 4-year-old male was found down in the pool, in a neighbor's swimming pool, actually, by a family after yelling for him around the house. They said he'd only been missing maybe for 5 minutes because they were loading stuff into a car to go on a trip. He was face down when they found him and pulled him out, and they called 911 as soon as they saw him. Initially, he seemed unresponsive. They weren't sure if he was kind of moving when they pulled him out. Seemed to have maybe a few shallow breaths. But the dispatcher told them to start giving rescue breaths, and he coughed immediately right after that. Upon EMS arrival, about 5 minutes later, he was crying. He seemed alert with some mild pallor, but otherwise normal coloration, strong pulses, minimal rhonchi without wheezing on exam. And these are his initial vitals. So his temp is 36.1, heart rate 140, 30 and crying for his respiratory rate. He's 91% on room air, and his BP is stable at 100/62. Feel free to throw in the chat if you have any thoughts about this case, if there's anything that stands out to you that you're either reassured by or that you would interpret as a potential red flag. Feel free to start putting that in the chat while I keep moving through our PowerPoint. Statistics for drowning. So unfortunately, this is one of the leading causes of death for kids ages 1 through 4. Bathtub drowning is more likely to happen in the 0 to 1-year-olds. Swimming pool drowning is more likely to happen in the 1 to 4-year-olds. And then kind of 5 to 14 is more likely natural bodies of water, lakes, reservoirs, some sort of recreational body of water. It is the second leading cause of death in ages 5 to 14. There's about 4,000 drowning deaths a year, which is still far too high for the information that we have, for the advocacy about pool safety, fences, being aware of your child, even the way we've developed, kind of like seatbelts have and car seats have changed, developed new flotation devices that are much safer for kids. When I was growing up in the 90s, it was still kind of that weird vest inner tube. And if you flipped over as a kid, you could not you have the strength to flip yourself back over. So you just ended up face down. Now we know like vests with arm flotations are a lot safer. But really, anytime kids can submerge their face in water, they're able to panic, they're able to start aspirating, and they're able to drown. So you can't just rely on flotation devices, you also have to rely on supervision. And then non-fatal drownings requiring ED care, about 8,000 a year. The regions that we see this the most in, Colorado is pretty high, but as you can imagine, coastal areas where people are at the beach a lot, Arizona, where every single person has a pool in their backyard, Texas, so areas where you see a lot more bodies of water kids can get into. This is just, again, representing that sort of peak heat is when we see peak drowning season. So we are right in it, and we're not seeing that heat let up. So I would expect it to continue through August. 2020, when everyone had to be outside, was one of the worst years we've ever had for drowning deaths, unfortunately, which just goes to show you, too, it's the access to recreation and just being around anything that's a body of water. What actually happens during drowning is that the submersion occurs first, right? You have to have the nose and the mouth fully under the water, which is why a bathtub with just a little bit of water and a baby who's face down and can't roll can cause drowning. What happens if you don't know to hold your breath or you start to panic and gasp is that you have this reflex laryngospasm. So a kid who's under the water and starts to panic is probably going to start gasping, crying, trying to basically speak much faster than someone who rationally is like, it's fine. I know I can go right back above the water. I can, float back to the surface and pull my head above the water. This is also why cold water can be dangerous because your body naturally produces that reflex laryngospasm. If you have kind of that shock gasp reflex when you hit the ice cold water, which is where polar plunges are wonderful, but can also, if not done with the correct supervision, correct understanding of what's going to happen to your body, be dangerous. The apnea occurs with that reflex laryngospasm, which then leads to obviously loss of consciousness and continued water aspiration. A lot of times we split it between freshwater and saltwater. 2024 guidelines basically said we're not going to care as much about that anymore, but just for your own knowledge, the freshwater is hypotonic, which dilutes surfactant and leads to a quicker alveolar collapse. So swimming pools included in that, whereas ocean saltwater is more hypertonic, is causing pulmonary edema a lot faster. So that's where like diving and some of our coastal drownings can look a little bit different on their initial presentation. You feel like you hear more water in the lungs faster. And it just has to do with those subtle changes in hypertonicity, hypotonicity. But ultimately, both things, the dilution of surfactant and the pulmonary edema, are going to happen. Because the second you have alveolar injury from that dilution of surfactant, the fluid's going to be pulled into the lungs and you'll get pulmonary edema. And then ultimately that leads to that VQ mismatch, right? Part of the lung has water in it, so you're not oxygenating that blood, the blood shifts elsewhere, and then ultimately you end up with this hypoxemia. So normal versus pulmonary edema, you're just seeing that fluid build up in the alveoli and then eventually leak into even the pleural spaces. Small pediatric airways, any kind of fluid in the alveoli is probably going to cause atelectasis and collapse a lot faster, which is why you can see kids turn into really critical respiratory cases so much faster than you would an adult. And that's why we take kids so seriously when it comes to drowning. It's also why it's one of the leading causes of death. So just thinking again about the surfactant lines, those normal alveoli, so the normal airway, it's helping kind of maintain that water balloon that it's open, right? Collapsed alveoli, you're essentially getting no air in. You still have all the vessels around here, but they're not being oxygenated. And then eventually that leads to damage to this alveolar wall, and the fluid is able now to leak into the spaces. And so the alveoli itself fills up with water. One of the other things that we changed was our approach to drowning in 2024. So I keep referencing this because this is the latest update, and it did have quite a few big changes. I'm going to list those a little bit more in depth after this slide, but that's why I keep referencing the 2024 updates. And so really, this is kind of a community approach. AHA is publicizing this for everyone, not necessarily specific to healthcare. But so you know, this is the advertisement that's out, right? We want to prevent more than anything. Supervision, barriers, life jackets, teaching kids to swim. We want to recognize silent drowning seconds, right? Kids are not necessarily going to be the splashy yelling for help like an adult. Usually, the problem is that they can't get back to the surface or they've panicked too much to get themselves back to the surface to do the splashy call for help drown. They just suddenly get tired, go under, and you never see them again. And that's why supervision is so important. And that's why pediatric drownings are so, so terrifying. Safe rescue, right? You don't want to put yourself at risk. We teach this mostly to lifeguards. But reaching, trying to throw a device, carrying a flotation device with you so that you're able to safely bring them back to land is going to be helpful. And so I don't know if anyone's on a dive team or has been involved in search and rescue, but that's why we talk so much about crew safety, life jackets, etc. Ventilate and CPR. So interestingly, and this isn't written here, but they actually started to talk about rescue breaths if you have a prolonged transport back to a dry land surface. Rescue breaths can make a difference. So these are more of the out in the ocean. It's taking a while on, a jet ski to get back onto land, or you're trying to swim back to land. Your safety is most important, but they've started informing people that any rescue breath you can give, especially to a kid, is going to be helpful. 30 to 2 CPR, this is for our teen and adult patient, 15 to 2 in our little kids. And then advanced care, oxygen, oxygen, oxygen. So airway and ventilation really are and have always been the top priorities. But unlike cardiac arrest from other causes, drowning is not traumatic, it is respiratory. And I'll talk a little bit about that point about not being a traumatic injury later. But really, this is sort of like our approach to any kid where we're expecting respiratory arrest led to cardiac arrest. The more we can deliver high quality ventilation, the better the outcome for that kid. And this is where I mentioned in-water rescue breathing can be life-saving for these kids. Oxygen administration, regardless of the drowning, can be helpful. So even if you're just sitting on scene with the kids, throwing them in oxygen while you're trying to finish your assessment can be very helpful. So what I would say as a rule of thumb based on some of these recommendations is if you hear that you're going to a drowning case, have everything prepared to administer oxygen, have a non-rebreather and have a bag. I would bypass the low flow. I would bypass the simple masks, and I would just immediately have your non-rebreather ready to go, but also have your bag ready to go because you don't know what you're going to walk into. AEDs are useful, but not always necessary. So that's where, you are less likely to see a shockable rhythm in a drowning case. Not that it's not going to happen, but you shouldn't necessarily be expecting to shock these kids. And so putting pads on, while can be useful if you're farther down the pathway and you have a longer transport, that shouldn't be as much of your goal. It should be more on ventilation. And chest compressions, I know this says compressions only CPR may be an option. That's really for rare cases. I would focus more on ventilating this kid as much as possible. And so don't skip those ventilations. One of the things people always ask about are warm versus cold water. One of the things, unfortunately, we have here in Colorado are lots of cold lakes. Our reservoirs are very cold and cold, creeks. People go whitewater rafting and fall out, even with, life vest on. They're encountering that cold water gasping reflex. And so cold water drowning versus warm water drowning, it really more matters when it comes to the actual temperature of the patient, and then potentially why they had such a rapid laryngospasm effect. Ultimately, hypothermia is possible for all children who are wet, regardless of whether this was cold or warm water, because that evaporative cooling that's happening in a very large body surface area of their skin is going to lower their core temperature that much quicker. So no matter what, if you have a wet kid, take off their take off their wet clothing, put them in a dry blanket, and get them warm as soon as you can, regardless of whether it was warm or cold. But just know that with cold water, sometimes the effects of hypothermia can lead to a more prolonged resuscitation. A clinical presentation of kids who are drowning. So not surprisingly, they're probably going to appear wet unless someone's dried them off completely and stripped them of all their clothing. That can be one clue, right? That this was potentially a drowning injury. More often than not, you're going to find a kid who's awake. Thankfully, for you all, and even for us, the specific calls that we actually personally take care of where we're seeing an arrest are a lot more rare. However, being aware that drowning can lead to an arrest and is a common cause of death in kids is always important. They may be crying. That's a good sign. It suggests that they're protecting their airway, right? And it lets you listen to their airway sounds. More often than not, you'll hear them coughing. Sometimes there will be a lot more secretions in their airways. You might hear gurgling, drooling, kind of clearing your throat type breathing. Rarely you'll hear stridor. Thinking of secondary injuries, potentially if you hear stridor, more often than not, it's lower airway. It's not upper airway unless they're still having that kind of laryngospasm effect in a potential arrest. The sick drowning kids, the way they present, they're pretty much always going to be either unresponsive, altered, or lethargic. Probably more floppy when you look at their tone, as we're using our pediatric assessment triangle. Profound distress, diffuse wheezing, rhonchi or diminished breath sounds, pale and weak pulses. I think all of us can agree if we saw a kid looking like this, we would know they were sick. We would know we were being aggressive in our management. But drowning is no different. Typically, children, if they are awake and alert on scene, will maintain that and will appear well for a period of time. The risk is that within 4 to 6 hours, they can begin to develop kind of that aspiration pneumonitis that turns into pulmonary edema. And so, a very well child who you have confirmed is a drowning is not a child that you should be saying, you're good, you don't need to go to the ER. The AHA across the board says pretty much any pediatric drowning should go be assessed and observed for a more prolonged period of time in an ER setting. Our protocol is typically 4 to 6 hours of observation. Oftentimes, we'll get an x-ray at the beginning, x-ray at the end, and compare the two to see if we've seen any progression, even if their vital signs look okay. And so we're just very, very careful because, as you know, any sort of aspiration of that water can cause the alveolar damage, can lead to more of that pulmonary edema cycle. Cyanosis is typically going to be a late finding. Sorry, my nose. But increased work of breathing, kind of respiratory rate that's higher than you would expect in a kid, especially who's not crying, would be concerning. The last thing I always like to say, I get a lot of calls, so the kid's agitated, and we suddenly go down basically a protocol for agitation. If I hear an insult that is likely causing hypoxemia, and then I hear agitated, I always assume that that is essentially air hunger and that the brain is screaming for oxygen. So I don't want to sedate that kid, right? I want to give them oxygen. I want to help them ventilate. So when you see a drowning case, the whole point of this slide is to say interpret agitation as air hunger, that the brain is hypoxic and that you need to ventilate the kid. So next steps for that case study, right? We already talked about warming and drying. We talked about either non-rebreather or bagging. He was awake, he was crying, so I don't think we need to start bagging the kid. I think a non-rebreather would be totally sufficient. What do you all think about access? Is access something for all drowning cases that you automatically get? Does it depend on how sick the kid is? Feel free to throw that in the chat as well. I am very curious. There isn't a right answer here. What I would say is in the really well kid who you're just on a non-rebreather, maybe seems stable, you probably can hold on access. But in a kid that you're like, this kid is giving me like spidey sense, not sure which direction we're gonna head. Even if he ends up or she ends up being okay, it is never wrong to get access on a drowning case either. And so I really do think it depends on how sick the kid is, but know that sometimes these can decompensate quickly. And so oxygenation, ventilation is really important. Access if you think the kid is sick. And if the kid is really shocky appearing, probably going to an IO while you're working on a peripheral IV will be helpful. So this is all the same information we've been saying. Ventilation is the most important part of drowning. Hypoxia is really the problem. Never give blow-by oxygen to drownings because the ventilation is the key, and that's not going to create any kind of flow or pressure for them. Elevated end tidal or altered mental status should require positive pressure ventilation. That end tidal is a clue that the kid is not ventilating well, even if they're crying. And then this is just an example again of some of the waveforms that you might see with a drowning case that should be more red flag. So similar to our asthmatics or any kind of obstructive picture, that physical fluid is obstructing their ability to breathe. And so you might see more of that shark fin appearance. So even if the end tidal is reading, 45, 46, but you're starting to see more of that shark fin appearance, that's a sign that they're becoming more obstructed with that fluid. Hypoventilation, if they're more apneic because they're so tired, is going to look like this. I've already gone through most of these. For the altered sick kid, sometimes you will be surprised how quickly they'll drop their blood glucose. So I added checking a BGL here. But really, your focus should always be on ventilation. And if you don't have the hands or the equipment or the people to check a BGL, that is not important. Arrest and drowning are usually going to be more of like a bradycardic, right? Their oxygen drops, their heart rate's going to drop and follow suit. PEA, very common, asystole a little bit later. So if you're catching them early, it's more of that bradycardic into PEA arrest. The asystolic arrests, they've probably been down for a while. High quality CPR, as always, 15 to 2 with high quality ventilation. One of the other things that's changed recently is we no longer advise for 2-finger on our infants. We advise for thumb encircling method. What we were finding is that the rate and the depth was not consistent with 2-finger. So infant CPR, thumb encircling method. If you have the ability to have a CPR coach, that's always helpful. Keep those kids warm, and then epinephrine is going to be really your only med that you're using. All right, so finishing up with our discussion on drowning, and we've talked a little bit about some of this, but curious for all 3 of these questions, how often have you or do you call for field refusals for pediatric drowning? What is your approach to transporting these kids? And should you consider all drownings to be a trauma? I'm especially curious about one because what I have found is that there will be a lot of parents who think their kid is fine and they really can get, more often than not, they're anxious, but sometimes they can get difficult to manage on scene. And it can feel like you're spending a lot of time talking to the parents instead of taking care of the patient when you're trying to explain that it is really important that you bring that patient to the ER. Oh, good. Well, I'm glad to see never called for a field refusal for a drowning. I probably, perfect, have been on the receiving end just of some of those biophone calls. And it's always about the parent or the guardian, and it's never about you all and your approach. So I think really just being equipped with the information that the AHA recommends that all pediatric drownings go to the ER. That's really all you have to say. And so the goal is any pediatric drowning should go to the ER or to the closest designated facility. And that's all you have to tell the parents. Always feel free, obviously, to call someone if you're having issues convincing them otherwise. And then no, you do not need to consider all drownings to be a trauma. Only about 0.5 to 2% of drownings have associated clinically significant injuries. The big reason being that kids are not usually the ones diving off of high places and causing kind of those dive injuries, C-spine or spinal injuries. More often than not, it's those silent drownings where they just can't get themselves out. And so a lot of people used to say you always have to maintain C-spine for drownings unless you have a really high suspicion based on the mechanism that you visualized or that was described to you, or injuries that you visualize on your exam, you should not have to worry about maintaining C-spine or transporting this as a trauma. And we've changed a lot of our protocols just this summer, actually, to say we don't need to activate a trauma every time a drowning comes in, because that used to be traditionally what we would do. What this all means, and as we get to our summary, is that pediatric drowning is fundamentally a respiratory emergency because the primary insult is hypoxia. That's what's creating all the downstream effects. That's what's creating all the problems. Unfortunately, for the kids that are non-fatal, but considerable injury, we will see them have that hypoxic ischemic encephalopathy, the brain damage, the cerebral edema. They'll be in the PICU for a long period of time. Sometimes they end up trached. It can be really difficult to see. And that's where effectively ventilating is really going to be your best bet for management for all kids. Non-rebreather, BVM, that's where you should start. That's where you should end. And then transporting all of these kids. Usually what happens for us is we'll get them to the ER. So this is just a case for the 4-year-old that we'd already talked about. We'll get the x-ray like I mentioned. So for this case, this was his initial chest x-ray. By the time he got to us, it had been like a 30-minute period after he was pulled out of the pool. His VBG was showing kind of a mild respiratory acidosis, a 7.349. He arrived appropriately on a non-rebreather because he was awake, alert, and crying. Sorry, now my dog has a squeaky toy in the room. And then we decided, we're going to watch. We're not quite sure if we need to admit or not. But unfortunately, he did start to escalate and decompensate. And 4 hours later, this is what his x-ray looked like. We ended up talking more to the family, and they think maybe they estimated wrong how long he could have been in the pool, and probably had a lot more of a significant aspiration, unfortunately. So had moved towards intubation just clinically, watching his end tidal go up, watching him become more distressed. He was grunting, he was head bobbing, he was tripoding. And then once we got the gas after we intubated, he had dropped down to 7.09 with a CO2 of 75. So this is also a big reason, right? We transport because you just don't know which direction they're going to go. For this case, I have 10 others who I watched for 4 to 6 hours. The repeat x-ray looked better or the same, and we sent home and they were fine. They always make me a little nervous to send home, but more often than not, the reason we watch for that long is because you will see those injuries develop. And so ultimately, in summary, obtain a full set of vitals for every kid, including end tidal. Like I already said a million times, be aggressive in your treatment. Don't be afraid of these kids. Don't hesitate to treat them. And administer oxygen, transport all drownings. I know that was a ton of information, and I really appreciate you being patient. I didn't end as early as I thought I would, so I apologize to everybody who's been sticking around this long. But please let me know if you have questions. And this is that QR code that we mentioned as well, so that you can get CME credit. Thank you all again so much for taking your night to do this with me.
Thank you so much, Dr. Jam. That was great.
Yeah.
Wonderful information.
And hopefully no one has any big drownings this summer. But I'll stick around for a minute or two if anyone has questions. Otherwise, y'all are free to go.